talk about. At the Global Liver Institute, we believe it all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live. Hello and welcome to this very special Women's History Month series for GLI Live. I am your host, Donna Cryer, the CEO of the Global Liver Institute. And throughout this month, I have used point of personal privilege to be able to bring you this fantastic slate of the most influential women in healthcare, but they're also some of the most influential women in my own history and my own, if I can be considered effective in healthcare, it is because of the wise mentorship and example of women like our guest today, Margaret Peggy O'Kane, who is the founder and president of the National Committee for Quality Assurance, NCQA. Peggy, welcome to the show.
Thank you so much, Donna. I'm really happy to be here.
Thank you. So, you know, when we hear acronyms around DC, like NCQA, it's easy to sort of take them for granted, or one, to assume that they were always there. That's not the case with NCQA, and assume that, you know, it does something that we could never possibly understand as patients and never really be a part of, and somehow they just sort of magically happen. But that's not the case either. What you do at NCQA is very important and impactful to patients, and increasingly we have a role. So can you tell us about the organization and about just what quality measures are?
Right. Well, we're a nonprofit. We were established 32 years ago. It'll be 32 years in April. And it was around the creation of a big movement about HMOs that employers were leading. So, you know, HMOs get a preset amount of money per patient. And basically, people worried that if they didn't have an open checkbook, that they would get they wouldn't get things that they needed. Mm-hmm. You know, so patients with difficult conditions, like the patients that you're talking about, mm-hmm. There was a lot of worry about that. And there was a general distrust, and the employers, remember, were driving this bus. Mm-hmm. And they were saying, well, they call themselves health maintenance organizations, but we don't really see the evidence that they're actually maintaining the health of our employees. So that's always, it's kind of like, what you want to do is find out what is somebody's problem and how are you going to go about solving it.
Right. So that's certainly how patients think about things.
Yeah.
So, you know, as we were talking before the show, I was thinking that there should be a Schoolhouse Rock for quality measures in the same way that there is for, you know, how to create a bill, because there is a process for doing this. You can't just sort of manifest a quality measure out of air. Can you tell us, you know, how an idea of what a set of services and interventions and medications and what have you that might benefit a particular patient population
right
into a quality measure?
Right. So let me start with preventive services, right?
Right.
So, you know, mammography for women,
mm-hmm.
You know, where the guideline says women over 50, between 50 and 75 mm-hmm. should be screened every 2 years. That's the Preventive Services Task mm-hmm. Force guideline. So we go in, we take the population of women in the health plan that are between those age ranges, mm-hmm. and we see how many of them have a claim for a mammogram. And, you know, that's kind of a very simple one. Mm-hmm. Hypertension, to get to really some of the things that have been on our minds a lot since COVID, because we realize that if you have untreated hypertension, if you have diabetes that's not in good control, those actually contribute to your risk of death in a very substantial way. So, those two alone are worth, hundreds of thousands of lives a year. So you try to pick things that are important, where there is some degree of consensus about what is the right level of control and so forth, and you go ahead and do that. So, diabetes and hypertension are kind of secondary prevention. So it's kind of preventing chronic illness from progressing and creating a lot of complications and death. So.
I think that, I had the opportunity to speak at the very first NCQA quality talks about, from my patient perspective, what makes quality healthcare. How do you bring different stakeholders together who might have different perspectives on what quality healthcare looks like? How do you create that consensus?
Yeah, I mean, we have a whole committee of consumer representatives that advise us and kind of look at what, like, the quality measures that we're currently working on. Say, why don't you have this? Why do you have that? And so forth. We've always had multi-stakeholder groups, including consumers, on our boards and our important committees, like our standards committee and our committee on performance measurement. And there's a kind of magic that happens when you bring people with different perspectives, different kinds of stakeholders together, and they can kind of work it out together about, like, this is important, but we don't have enough science on it. So, so it's really a big collaboration across stakeholder groups. Has
it been helpful to your process that patients are now involved, further upstream? So as patients and members of the public are involved in the development of the guidelines themselves, or of I've seen, patient-reported outcomes and are generating the evidence that then you can include in your process. Have patients being involved sort of further upstream been helpful to you?
Yes, and there's a lot more that could be done. And I'm going to just give you my pitch,
please,
on why we need to fulfill the promise of digitalization in healthcare. And that we had the High Tech Act back in the Obama administration. We spent a lot of money, and medical practices are now equipped with electronic health records. And yet a lot of that data is not used to really understand better how to refine the process of care. Yesterday I was listening to a woman who runs a hedge fund on innovation. Her name is Kathy Wood. And she was saying healthcare is about to become informed by science in a big way. And, we laugh because we know it's a struggle, though, right? Because she said, the doctors are certainly smart enough, but they haven't had the data, and they still don't.
Right.
So we've been practicing from clinical trials that are very narrow and so forth. And we're about to be able to learn from big data that's generated from real patients, and we want their outcomes to be reported as part of that, so that we can really generate much more customized information about what to do for this patient in front of me.
Right.
So I hope I didn't go into too much rigmarole there.
That's perfect. And it's something that we talk about with the patients in our Advanced Advocacy Academy, about the use of real world evidence and why things don't seem to reflect how they are experiencing care. I remember when I was on an NIH Learning Health Systems committee, and I said, if we are going to have a learning health system, we have to first start by admitting to patients that we haven't been having a learning health system to date. I think most people assume that well, all the information from every visit and certainly everything in their electronic health record is analyzed in a way to improve care. And we're really, unfortunately, just at the beginnings of that.
Yeah, it's really frustrating. And so I encourage you and all these people you're training, we need an army of people that are demanding that healthcare do better for patients.
We absolutely do. We have webinars scheduled in patient portals. I remember the HIT policy committee, my mind being blown when some systems weren't turning on the patient portal feature in their EHRs. So it wasn't that they didn't have it; they just chose not to turn it on so that patients, wouldn't have the data.
Or they have it, they have a little pocket over here where that data goes, which never intersects with the other data. And so there's just a tremendous loss of the potential that we have to really do a fantastic job.
And it's so, when you talk about quality and being able to deliver quality care, just as a personal example, I remember the moment my long-term data from the Johns Hopkins Medical System connected with my more recent data as Sibley Hospital became part of Johns Hopkins Medicine. And all of a sudden we had trend lines going back 30 years. And so some things that I had been, maintaining, asserting as a patient, I'm like, I could have this hemoglobin, and they're like, I don't really think so. But then they were able to see, oh, well, you did, like your norm, if we really look historically, was here. I guess we can try to get, and I'm healthier today for it. We were able to avoid a surgery because we were able to have access to that historical data and to be able to look at things differently. Like, I don't think we need to have surgery. Maybe let's wait a day or two. It looks like, she has a pattern of being able to resolve medically. And so the power in that data, the impact on being able to deliver personalized care, deliver high quality care, is just so powerful. It's just so powerful.
Yes.
So how did you get to be at the helm of this, incredible organization?
Oh, I was hoping you were going to ask me about my personal journey because it's really pretty interesting. I was a French major in college and, including I went to Paris for my junior year abroad. It was all very nice. And I thought I was going to be a French teacher. But, I kind of after studying French literature for intensively for a year in Paris, I thought, no, this isn't really what I want to do for the rest of my life. And so I kind of started a journey of trying to figure out what I wanted to do. And I taught second grade. I worked in a lab, but I kind of found out about a new field at the time called respiratory therapy. And I became a respiratory therapist, which at the time you could just walk in and they would train you on the job, which is kind of insane, but and I did eventually pick up a degree in respiratory therapy. But the experience of working in hospitals, and I worked with children with cystic fibrosis, which is, really, that's an amazing story in its own right about what they've done as parents with that foundation and so forth. I worked with people in the intensive care unit. I worked with people that had chronic obstructive pulmonary disease who were very, very sick. And there were a couple of things that I walked away with. First, the one that put my hair on fire was how disorganized the care was and how it really mattered that the care was disorganized, that things were done that were harmful to patients, not because of any one person usually, but because the different ones weren't talking to each other and there was no grand plan, So that was when I decided, and this, I did it for 5 years in different hospitals. I worked at UVA, which was actually the best. And I worked at others I won't mention that were terrible. And, but even UVA had a lot of quality problems. So when I got out of that, I went to Hopkins and I went to my first graduate seminar, and I said, I want to work on the quality of healthcare. And I remember the professor saying, what do you mean? We have the best healthcare in the world. And I said, how would you know that?
Right. That's exactly the question I had. How would you know?
Anyway, so at the time, the quality field was really in its primitive stages. Doctors were reading each other's charts, peer review. There were no standards. There was actually an idea that if you lived in Seattle, the standard of care was probably different than standard of care in Boston, even though your human biology isn't different, right? So it took a while, but these employers that helped us shape NCQA, and I worked on this for a few years before NCQA was actually established. The employers did push it, and that's how we got here. But we did everything we could with claims data, and we're now at a moment when we are just chomping at the bit to move to the big data that's going to allow healthcare to really soar and do better.
We really appreciate that as a patient advocacy organization because, of course, we don't typically have access to that data.
Right.
Part of the privilege that I've had, whether it's leading PCORNet for a year and being able to go to the data center at Harvard and being shown, all the fancy tricks that could be done with large data sets. I was like,
that sounds great.
Ooh. It was like a kid in a candy store. I was like, well, so you mean you might be able to answer this question? I was like, and the thought running through my mind was if other patient advocacy organization leaders knew that there were these large data sets that could answer these questions that we had, we would be able to, build our programs and services and advocacy with so much more precision, so much more impact. There's a lot of resources, being done at various, levels of quality, because it's not our core competency as patient advocates in setting up, registries or doing surveys and trying to get them powered. And when these fantastic, data banks and resources, exist, both of actual care and of then the claims, the health insurance data, which sometimes differ a little bit, but both are very valuable. I think also as we are being asked as patient advocacy organizations to make cost effectiveness arguments or justifications for treatments for our various conditions, partnerships where we have access to that type of information to understand the impacts, at least upon the care system, that we can supplement with some additional patient-generated and caregiver-generated information, really has an opportunity to be really transformative in how we understand the impacts of various conditions, but also of the interventions that we've used so far.
Yeah, Donna, I wonder if I could share this story that kind of has been on my mind since I read it. So Israel, Israel's a small country. They spend 7% of their GDP on healthcare, believe it or not, 7. Everybody in Israel, well, they have, there are pockets of populations that are left out, and I don't want to go into that, but, it's not perfect. But if, the population of Israel, they all belong to one of 4 health plans. And when COVID first surfaced, Israel, and everybody has an EHR, they're all on the same system. Israel went to Pfizer and said, we would like you to give us a good supply of your vaccine. And in return, we will monitor what's going on with our patients, with our citizens who are getting vaccinated. Those health plans, I have friends who are Israeli. They reached out to people They got them in, they got their vaccines. It was it was not like here. You remember those days, right?
Yes.
You were in the early group too.
Yes.
So they vaccinated their people. They were, I just was reading in December about their analyses of Omicron and so forth. Just think of that. It's just one little case study of what is possible.
It was very important to us. We were looking at that Israeli data, and then data coming out of some of our European partners to inform what we were advocating for in terms of U.S. policy and access for vulnerable populations. When you coupled that with decisions by the for incredible transparency from the Johns Hopkins vaccine effectiveness study, so that we could understand who wasn't responding and who needed a third shot. But without that data, our advocacy would not have been effective.
Exactly. But I mean, even, if you think about the way a lot of people get healthcare, they're often seeing different kinds of doctors who may not work in the same system. Therefore, like you see, if you're lucky, you see your own treatment data as a doctor, but you're not seeing what else is happening. And the more complex the patient is, the more critical it is that you have a complete picture, right?
Absolutely. And it is very hard to integrate, because I see several ologists, and
I'm sure you do.
and to make sure that they are informed and are receiving the data amongst themselves when it's a mix of academic and community practices, so that there are no missteps or misunderstandings or misalignments. It's both at its best, it's being on the same page to have the best outcome for me. At its worst, it's a safety issue.
Absolutely.
That they all have the same information for someone as complex, and that's both outpatient and inpatient data. One of the things I hear most often when I'm talking to physicians as they're struggling is that they may have a patient who's admitted to the hospital and they never knew about it, and medications are changed, and all sorts of decisions are made and things done, and they may only hear about it as happenstance if a patient if their patient shows up a few days or a few weeks or a few months after that hospitalization. And so when we talk about a system of care and defining what quality healthcare really looks like, it has to be better organized and better coordinated across the different practice settings, more organized by I always feel that the data should follow the patient, rather than worrying about the silos of the different EHR systems or the different clinical practice settings. And so that I think is part of being able to understand what quality care really looks like. So often patients come to us and we're able to interject into conversations that actually the patient was also receiving this and this, or doing this at home and this addition. And so if the outcome is attributed to these two things, for example, that are happening in the healthcare system, when it's really those two things plus four things that the patient was doing on their own, then we have had an incomplete picture and may not be measuring the right things or understanding which are the points of leverage that could actually make a difference.
Yeah, I mean, your point is so well taken, and like using that portal as a real source of information that's critical to the delivery of high quality care. That's a mindset that's not here yet, right? It's researchers are doing it, idealistic people are doing it, but it's really not arrived at scale in the way that we need it to.
We've made such a difference, though.
Yes.
I remember early on in my career where, the thought of patient-generated health data was laughable. And then I go to, was a very large and well-resourced and well-coordinated academic medical center. And I felt sort of like all my advocacy dreams have come true as they apologized to me because my, biopsy results would take, 3 days to be in my record. And I was like, I remember fighting to get that data at all, and you're apologizing that it's not coming fast enough. I'm like, we've come a long way, and the fact that patients are involved in that process and is is something that I remember just being.
Donna, it's so important to kind of take stock of the good things that have happened, because I know that's part of what gives you the energy to continue your important work. It really, I mean, those of us that have chosen to do these, these jobs that are never like, there's no silver bullets.
Right.
You never can declare victory. It's really important to look at those little milestones and say, look how far we've come in the last whatever.
Absolutely.
Anyway, yeah.
So to this new generation, this upcoming generation, who we hope will decide to make healthcare their future, their career, what advice would you give them?
I would say, are you talking about professionals?
Professionals, yes, yeah, professionally.
Yeah. Don't be silenced. Make sure if you see something, say something, right? It's a really important point. Always keep the patient in your heart. That's to me like one of the motivating factors of my career is I think of real people. And because it can feel like it's all very technical, and you and I know that it matters a lot that people get the right care. It can make the difference between life and death, or between a high quality life and a life where you're just struggling and depressed and messed up. So I think to kind of seek those sources of motivation, and also like the thing we just talked about, celebrate the little victories. Be assertive. Women, I don't know if you observe this, but I don't suffer from this. I don't think you do either. Women are often very reticent and reluctant to speak, and we can't be like that. We need to get our point of view across. And if our point of view is repeated by somebody of the other gender, and it's they're taking credit for it, you can remind people that you brought it up first, and so forth. So I think we're working against a lot of cultural, leftovers from these things. Don't go away in one generation. They're just things that we need to be aware of, and we can do it in a kind way. But it's very important to. Women have so much to contribute. And I think in healthcare, you see it. You see that there's part of the way we're socialized is to be more caring. And so that's a strength and play to it.
I couldn't agree more. And it is something that I had to teach myself and sort of hold myself accountable to, having gotten that seat at the table, how I was going to use it for everyone else who wasn't there, for everyone else who didn't have that opportunity. I also, to the point of, living long enough and doing this work long enough to have the thoughts that I had and, in my head sort of quietly sitting there when I was, in my 20s at the far end of the table. And I was like, well, I was right, and after a decade or two of being right in your head, you figure, well, you might as well just say it out loud, because you're likely to be right as the other person who is just expressing themselves, and so I think that just sort of putting it out there, and now it's sort of a superpower of saying the stinky thing in meetings that everybody is thinking, but everybody else is afraid to say.
That's right.
And to me, it embodies my favorite definition of patient engagement, is that it's sort of a negative one, but it says, if nothing changes when you were there, then it wasn't patient engagement.
Mhm.
And so I think about that, in every meeting or board or call I'm in. Has something changed because I was there? Because I could did I make a contribution? Because I can't be just there to warm a seat, because then I should give it to somebody else who's willing to step up and show that courage and make that contribution on behalf of everybody else who can't be there. So
yeah, that's right. I mean, I think on the other hand, also, when we encounter a great nurse or a great aide or whatever their status is, to connect with them just briefly and thank them. I mean, watching what healthcare workers have been going through in this country for crazy reasons, I think of, like, they need our empathy as well.
Right.
And that strengthens them and gives them, there's a kind of virtuous cycle there of their empathy, then their reserves are fed, and then they have more to give to their other patients. So
absolutely. I really relish the opportunity to sort of create space for their voices and their input, these days, and make sure that they get the attention that they need. And those are things that you've taught me, Peggy. So thank you. And thank you for this conversation today.
It's my pleasure, Donna, and keep up the great work that you do. You're an inspiration.
Please be sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.